going on there is like we talked about, and I talked with some of you about it, but like we talked about with the reflex hammer and the knee, if you have your knee in a bent position, the quadricep is already on a little bit of a stretch, and then you give it a little bit of a tap that tells it it's getting stretched even more, that muscle is going to automatically kick in. So when you have somebody that's weak in whatever, if you give that muscle just a real quick stretch, not a ballistic stretch, not really, because ballistic is like a really fast movement and repeated and for distance. A quick stretch is really not quite that. It's just a quick push in the opposite direction to get that muscle to fire. So if somebody's having a hard time getting that muscle to go, give them a quick stretch, it'll help them kind of initiate movement in that muscle. Does that make sense? And it works on literally any set of muscles at all. So when you have that patient in rotation, and you're trying to get them to rotate forward, if you give them a little bit of push back into back rotation, they're naturally gonna go the opposite direction. They're gonna kind of fight that to prevent a tear. Okay. The only other thing, it's good because all the stuff she went over, we were gonna cover eventually. So like, it doesn't really take any time from us, I don't think. And it's PNF stuff is some of the best stuff for really helping people. Man, it's all good. The only thing that I would adjust in what she said is if you have a patient who's already struggling standing, adding resistance to that, not such a good idea. Does that make sense? So, like, if they're having a hard time standing up as it is, and you're trying to resist them as they're standing up, that's just going to make it worse. Okay? So if you want to strengthen the quads so that they get to where they can stand up better, you can still do slow reversals or agonist reversals, but you would just have them either in supine or on their back, and you resist them as they come out, and then you push in as they go in as well. So you're still strengthening the quads and getting them ready to where they're able to stand up, but you wouldn't ever resist a patient who already can't stand up. Does that make sense?
I have a question. Because it was kind of an awkward resistance. Like, I don't know. Like,
It is a weird one.
Like, it almost pushed, like, me and Alex were working together, and, like, it kind of pushed us off balance. Like, even not needing to, like, be able to stand. And
Yeah, honestly, just to be perfectly honest, if I was gonna do that, okay, somebody come here. I don't care. Good. If you really want to resist somebody in standing, okay, and still resist the quad, all right, I want you to stand up for me, okay? Can you stand? Oh, yeah, stand up. Okay.
I like that better. I like the placement better. It was just awkward.
Like, it is a little weird because you're almost pushing them back.
Right.
That's why when she stand up, I was like,
I know.
I don't know that I can.
Yeah, so part of the thing that you'll find with physical therapy is there's more than one way to skin a cat, and different people like different things. Hannah, that's a weird thing. Like, once you really think about it, you're like,
Is there?
why are you? And
Why do you know that?
I'm pretty sure the FBI is looking at you, buddy. But anyways, beside the point, I digress. I'm sorry. It is a weird thing. There are different ways to go about different things, and just because somebody shows you something doesn't mean it absolutely has to be that way. You can always stop, and that's the power of Therex. And Jacob has brought this up a few times to me. Is that the real challenge of Therex is there's about 1 billion different exercises and about 1 billion different ways that you could go about it. That's why my goal really is to just give you the basic understanding. And so, would I probably put my hands there? No, I probably wouldn't do that. Does that make her wrong? No. It just means she goes about some things a different way, but the base concept is still a good concept to really understand. Would I ever resist a patient that's trying to stand? No, I wouldn't ever, because they're already a balance risk, and they're having a hard time standing, and you're gonna be pushing on them. Not a chance, you know. And so, but you know, maybe somebody else, as long as they've got a belt on them and they're keeping them safe, that's really their prerogative. Okay, and so, but the underlying concepts, if you get those down, you can do that with any set of muscles, any set of groups, and you just put your hands a little bit different. Even if you wanted to put them on top of just like the iliac crest and just kind of hold here, that seems a lot less awkward to me. You know?
Kind of in the same way, the resistance in the opposite direction,
Uh-huh.
like while they're bridging and putting your head underneath as they're, I kind of felt like I didn't really feel like I was getting resistance.
That one's a little bit tougher. You have to kind of get a flat hand and you have to get under there. You almost have to get, and not even as much the butt as the low back a little bit, so that you're still resisting that, but you really have to kind of get under the back. I would have placed hands a little bit differently on that. Does that make sense? Like, anybody want to let me demonstrate? Okay. I won't grab butt. All right. So just lay and do a bridge. On going down, I would get up behind them and get like here, so that you're more under the back and you're still able to resist. Okay, push, 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 push down. Okay. And then if I'm doing a reversal of that, the agonist reversal, I want you to resist me, but come up as you go. Go slow, go slow, go slow, go slow, go slow, go slow. So you're much more underneath. Does that make sense? And you have a little bit better grip. If you're really trying to get the PSIS, there's too much stuff in the way, and it does get a little awkward too.
How do body mechanics play into that? Because I feel like we're really bent
You
over.
just have to do your best to get onto the table with them and get in a better position, but it is hard not to.
Is there another way to achieve that without literally holding them up in the air? I feel like the body
Yes.
mechanics on that are not something I could do over 20 years of my career.
Well, and probably not. There are other ways to do that. What's going on there? So let's think thorax, okay? What's going on in that position? Like, what are we strengthening?
Like as the PTA.
Yeah, what muscle are you strengthening? What?
Glutes.
Glutes and what? And quads, right? So, yeah. Okay. Bridging, I used bridging mostly to get them to where they could do bed mobility. And then if I'm really going to strengthen quads and glutes, there are definitely other ways that you can go about that. Get them sitting, do long arm quads with resistance, do holds, do any of those things, but just specifically with the quads. And then you can focus on the glutes as well. But there's also even just extensors, right? You know, so you can work on just leg extension. And so there are ways around almost anything. Just go, I can't really do that, but what am I trying to strengthen quads and glutes, or if I'm going the other direction, hamstrings and abs, right? And so just go, well, I don't want to stay in that position. It's uncomfortable and it's not the best body mechanics for myself, so I'm going to change it up. I'm going to strengthen the quads and the glutes in a different way. Does that make sense? So it's always okay to go, that hurts too much. I'm not going to be able to do that over the course of my career very many times. Let's change this up a little bit. Always acceptable. Any other questions over any of that? Okay. Groovy.
Would you look, when she was demonstrating sitting on the ball over there, would you be able to use that for stabilization?
Oh, sure. Yeah, like once they've gotten really pretty good at balance a dynamic balance, but you're still feeling like their core is a little bit weak for like standing. Like if they're able to stand, but they start to get kind of tired and their posture kind of starts to go, and then their balance kind of starts to go, it's because they haven't gotten those type 1 fibers really strong enough yet. So what you can do is you can put them on a ball, okay, to do almost any exercise they're doing, and the whole time, what are they having to fire? Those core muscles, all of them, and specifically those type 1 fibers to really get going. So if you wanted to like progress them, at this point they would probably almost already have to be at least standing, because like that sitting, they've already obviously achieved everything they can. But like I said, if they have postural problems because they can't stand straight long enough because of abs or extensors, you can still, and so you could do any of these agonist reversals, antagonist, alternating isometrics, rhythmic stabilization even, you could do all while sitting on the ball. So you're adding extra strengthening into the already built-in isometric, more isometric, I guess, strengthening of just sitting here. Does that make sense?
Yeah, would that kind of be like, also doing quick stretches, because you're trying to balance?
It's not necessarily like the quick stretch concept, but it is just getting that proprioception a little bit in, and just that constant firing of the muscles to keep that balance in all those different directions.
Would you say using a lightweight medicine ball with that?
Sure.
Would that be
Like using something like this and then having them even do like a PNF pattern while they're doing that. Okay, so yeah, that could be great. Pretty highly advanced, but if they're somebody who is pretty dynamic in sitting, but once they get to standing, they're real bad, you could have them sit on that, use a medicine ball and do different actions, even throwing and catching and things like that, to where you're strengthening that trunk overall. Sure. Anything else? Okay, going back. Now we got to kind of change our focus. And go back just a little bit, but it won't take long. And honestly, she went over some of it again. All right, so we went over closed chain, open chain. Any questions over that?
No, I don't know how to ask that. I was thinking about it in my head.
If you guys come up with anything, just let me know. Come on. There we go. So there are some principles. These will be tested on, just to note, okay? These specific exercise principle. The overload principle is just, in order to get a muscle strong, you've got to get it to do more than it's already doing. You have to give it more of a load. You have to even overload it. You have to exercise it to the point of fatigue to get it stronger. Okay, that's really that principle in a nutshell. Okay, that's the boiled down version. The SAID principle. Oh, what did I do? No, man, I have to go all the way back. So exercise principle. Okay. So the SAID principle is just the specificity of specific adaptation of imposed demand. Okay? It's based on Wolff's Law, and basically what it's saying is that your body adjusts to whatever demands you place on it. Okay? So if you're somebody who lifts boxes all day, your box lifting muscles are gonna be the muscles that get strong. Okay? That really is the concept. If you're a bow hunter, okay? If you're somebody that shoots a bow or is an archer, even for just whatever reason, guess what muscles are gonna get stronger on you? The muscles that you use all the time, okay? So the middle rhomboids and your even your triceps and things like that, those are going to get really strong. But nothing else that you aren't working isn't going to get strong. That's really the said concept. So you want to work on whatever a patient really needs, basically. If you're running for a marathon, whatever you do, you want to strengthen more of endurance type muscles. Okay, so even your exercises, it's not that you shouldn't also lift, but if you are lifting, you want to lift more for endurance and less for strength. If you're more of a strength person, if you're somebody who needs explosive power like a sprinter, then you actually want to lift for strength because of the muscle type fibers that your body's going to adjust to. So this principle works in two ways. Yes, your body will adjust to whatever you're doing, and that's the main principle. But also, if you're wanting to work with somebody to help them in that area, your exercises should be focused in that direction. Make sense? So a marathoner, I'm working more for endurance type stuff. For a sprinter, I'm working more time towards strength type stuff. Okay. Specificity of training. Similar concept. It just says that this concept states that the adaptive effects of training such as improved strength endurance are highly task specific. Therefore, exercises in a training program should mimic the anticipated function. Okay? So you want to, with any of your exercises, mimic what kind of things they're going to do. I worked with a patient that was a shot put thrower, okay? High-level shot put thrower at one point, so I worked with them on rotational tasks. I worked with them on explosive strengthening muscles, obviously, and also on your more pushing muscle, okay? So more of extension, especially for the arms. And it's just basically that overall concept. And anything that might be needed to adapt to that they might not think about, like hand strength and other things. So you just kind of want to make sure that you take your training and build it into whatever's going on with that patient. If you have a patient that's struggling with lifting glasses to put them in her cabinet, you want to kind of focus on strengthening and even endurance a little bit and specific muscle groups. Okay. And reversibility principle. If you don't use it, guess what?
You lose it.
It goes away. It doesn't matter how strong you were at one point. If you don't continue to exercise, you'll get weak. Okay. Our muscle fibers, they say, with stretching, like if you get a patient to where they're fully stretching again, but they don't continue to, not even stretch, they don't have to stretch, but if they don't use that increased range of motion, within 4 weeks, they'll be back where they were. Okay? Same thing with muscles. They say 1 day of gains can be lost in 3 days of not working. Okay, so 3 days, you can lose 1 day of gain. Okay, so if somebody worked out for years, it might take them a little while to really get weak, but it doesn't take very long of sitting idle, doing nothing, before you really can get pretty weak, no matter how strong you were before. Okay, so it's reversible. Whatever we do good, whatever we do good, I just killed myself. I'll have a bruise now. Can get worse. Finally, the fatigue principle. Eventually, no matter what you're doing with a muscle, it will get tired and start to fatigue. And fatigue is actually what we want to get our patients to when it comes to a muscle, because that's when building and repair of that muscle kicks in, and that building and repair is what makes them strong. Okay, so here are the signs and symptoms that you need to be aware of, that you'll need to even teach your patient about. It'll feel like the muscle is starting to kind of contract on its own and cramp. You just kind of get that feeling, okay? When you feel that feeling, you started to fatigue that muscle, okay? Tremulousness, which is just that shakiness. You know, when you get to that point when you've done your 7th or 8th rep, and especially right in this range that we talked about earlier, you start shaking, that means you've hit that point of muscle fatigue, okay? Active movements are jerky, not smooth. That really comes into tremulousness. It's the same thing. That's repetitive. Inability to complete the movement pattern through the full range. If you were going through the full range pretty good, and then all of a sudden the last 1 or 2 you get to about here, and you're like, I can't finish it, you've hit fatigue, okay? Use of substitute motions. We've talked a lot about this one, but you hit that point and all of a sudden they're starting to try and use other muscles or move their body around. They've hit that point of fatigue, okay? Inability to continue low intensity physical activity. If they just get to the point where they're like, I can't move, okay? I can't keep doing this, you know they've actually hit a point of fatigue. Decline in peak torque during isokinetic testing. This probably will never come up for you, okay? But if they've been at a certain amount of torque and all of a sudden it starts to drop, okay, you know that they're getting tired. You know that muscle is starting to fatigue. Okay, so muscle fiber types, we've gone over these ad nauseum. Type 1 are those tonic and slow twitch. Your postural muscles, the muscles that last a long time, the muscle fibers anyways that last a long time. Your marathon type muscles, your standing all day type muscle fibers. And then type 2 are your muscles that are fast twitch, explosive movements, powerful movements. And then you also have type 2A fibers that are kind of a mix of the two, okay? They don't last as long as the postural ones, but they don't tire as quickly as the strength explosive ones, but they don't ever get quite as strong as those ones either, okay? Energy systems. So this just goes back to those same muscle fibers. Some of your muscle fibers run aerobically, meaning they run off of oxygen. And once your body depletes itself of that oxygen, they start to not fire anymore, okay? So these are your, what type of muscles would be your aerobic muscle fibers?
Large muscle group.
Your large, the type 2, those explosive, powerful muscle fibers. Anaerobic, these, did I say it backwards?
Yes.
I apologize. Backwards. So anyways, the oxygen ones, you have plenty of oxygen and they run backwards. I apologize. I said it backwards. And then anaerobic are the ones that they burn quickly and less efficiently, and those are your larger type muscle fibers. Sorry. Anyways,
So anaerobic is type 2?
type 2. Anaerobic is the type 2. Aerobic is type 1, according to. So, anyways, know that the point is to get fatigued, so you have to constantly change what you're doing with the patient, because if they start out and they're able to do just active range of motion against gravity, right? And that fatigues them for a time or two, but then all of a sudden they're able to do it really, really quick and without any fatigue. What do you have to do?
Change.
You got to change something up. You have to add some type of resistance, or they won't continue to strengthen. That activity won't get them to the point of fatigue unless you change something. Okay? whether it's changing the number of reps to where they just keep going until they finally hit that fatigue, which is kind of boring, but yeah, you could do that. Or just add extra weight to where they are still hitting that point of fatigue. That's really the point of all of this. So in order to do that, we go through progression, and it's called progressive resistance exercise or exercises. Okay, PRE. And when you're constantly adapting and changing to the progress that the patient has made muscularly, you're doing progressive resistive exercises. Okay? So, an example that they're giving here is you have somebody doing scapular retraction. If you do it here, okay, this is less resistive than if they put their whole arm out. Why? You're fighting more against gravity, basically. There's more part of the body that's having to fight against gravity, and there's more weight thrown into those muscles, basically, okay? So, when you go from this to this, you've done progressive resistance, okay? Then you would maybe have them start adding a band, and so on and so forth, or whatever, okay? So, when you are working with a patient, you only want to change one or possibly two things at a time. You don't ever want to change 4 or 5 things, because you don't know what it is that's like causing a problem for a patient or what has been adjusted. So pick 1 or 2 things. So if you were doing this, then just change it to this. Or if you were doing this and they were only able to do 10, move it up to 15. Don't try and change it from this to this. Add wrist weights and make it 15 reps. Why? Because when they start to fatigue, you don't really know what you should adjust because you've adjusted too many pieces. Adjust one thing at a time, and then you know how to adjust it. So if you go, okay, well, we're going to do that. You've been doing long arc quads with a 5-pound ankle weight, 10 sets, and that used to fatigue you, but now it doesn't. I have 2 options. I can either increase the weight or I can increase the reps. Okay? If I increase the reps and they get to 15 reps and they're really starting to fatigue or maybe too much, they can't get through 3 sets of 15 reps, then I know, well, 10 isn't enough, 15 is too much, so what do? 12 or 13. Right. So it lets you know where you can make adjustments a little bit easier than if you throw 3 or 4 different things in it, and then you have to kind of slowly unbuild what you've already built. Does that make sense? All right. So, okay, basically, we've already talked about progressive resistance exercises. Within progressive resistance exercises, you have your rep max, okay? There's different types of rep max. You can have a 1 rep max, you can have a 3 rep max, you can have a 10 rep max, okay? It's just how many times you or the person or the patient can do that weight. So I might be able to do a 20-pound or 25 or 30, who knows, pound weight 1 time, but if you ask me to do it 3 times, I'm not going to be able to do it, right? It might have to be a 20-pound weight for me to do it 5 times, or 10 times, it might be 15 pounds, right? Does that make sense? So anyways, there are general guidelines for how to strengthen a person to get that proper fatigue that you need. And the biggest ones are the DeLorme and Oxford regimen. So what you would do is you would find the patient's 10 rep max for either one. Okay? So you start them with, you give them a dumbbell, maybe it's a 3-pound dumbbell, a 2-pound dumbbell, whatever, and they do as many as they can. If they only are able to do 6, you need to go down a little bit more. Okay? If they do it and they do 15, you go up a little bit more, but you find what they can pretty much do 10 times fairly easily. But right at the end of that 10th one, you start to see a little bit of fatigue, or they start to tell you, I'm starting to feel a little bit of something there, right? Okay. So what you do then is, depending on which regimen, you can go at it backwards or forwards. Okay. The DeLorme regimen starts out with 50%. So say they are able to do 15 pounds 10 times. Okay, you would start them out for the first set with an 8 pound or 7.5 technically. Those don't really exist for the most part. Okay, so you might start them out with 8 and then move up to 75% of that, which would be like 11, 12 pounds. And then the final set, they would do a full 10 reps with 15 pounds. Make sense? The other one is just the opposite. You start them out at the highest, so they would start out with 15. Okay, they would do their 10 reps with 15, and then they would slowly move down from there. Okay, so having said that, you will start to get a feel for where a patient's at by just kind of watching them, and you'll go, you're probably a red TheraBand, and you'll grab a red TheraBand, and you'll give them 10 or 15 reps, and you'll see where they're at, and you won't go through this whole thing in real life. You'll just watch them and make sure they're getting to that point of fatigue the last 2 or 3 each time that they're doing. You just kind of do that. But the technical, right, book answer way, I've never, I don't think I've ever seen a therapist sit down and try and figure that out. Not a single time. Okay? Because you just kind of start to get used to it and kind of get a feel for it. But it does give you an idea of how to achieve that muscle fatigue if you're looking for something. Okay? All right. So, just some terminology. Strength training is obviously any muscle activity where you're raising and lifting a resistance or a load. Okay. Power is how much strength and speed you need to get that moving. Intensity is the amount of weight, basically, that you're lifting. Volume is the number of sets and reps that you're doing. Frequency, okay, these are things that you would possibly document, is how often you're doing it. Like if you're doing 2 or 3 times a week legs, 2 or 3 times a week arms or whatever. Does that make sense? And then duration is the number of times or how long you're going to be doing that program, basically. Okay. So, strength training zone. This is just a different way to approach it. Instead of the Oxford or the DeLorme, there's also, you can just go, well, if this is the person's 1 rep max, if you want to do 90% at 4 to 5 repetitions, that's going to get fatigue. Okay? If you know their 1 rep max, then at 75%, it's going to be 10 reps to get fatigue. At 60%, it takes 15 reps. At 50%, it basically takes 20 reps. Make sense? Questions over any of that?
So is there different, I guess, things you want to achieve if you do these different type of, intensities or percentages?
It just kind of depends, and we'll actually get to that in just a second. If you're trying to build overall strength and power, and you're trying to build more of those type 2 muscle fibers, you want to do lower reps, higher weight. Okay? So if you're just trying to go straight for bulk and getting stronger, period, and get those type 2 muscle fibers, you're actually better to do higher weight, fewer reps and sets.
So, and then
Okay.
when you do something like that, does that make the muscles tear
It does.
just more intensely, I guess?
Oh, yeah.
Okay.
And so the more you can get done with higher weight, the quicker you get pure like strength and power, so to speak. Endurance is the opposite. Okay, so if you're trying to build more of the type 1 type fibers, you want to, and endurance, muscles overall, muscular endurance, sorry. Then what you want to do is do less weight, more reps. Okay, so you might pick about 40% of the max and do 20-25 reps. Does that make sense? And so it just depends on what you're trying to do. The sweet spot that most people tend to shoot for is about this 75 to 60% of the 1 rep max in 10 to 15 repetitions, because it's a little bit of a mix of both. Okay, you can still build power that way easily, and it does also help with a little bit of endurance as well. There's a little cross effect there. All right. So sets we already talked about. There's not a kind of, but there's not necessarily a right thing. Most people do 2 to 4 though. Okay, because you don't want to over fatigue muscle. So 2 to 4 kind of tends to do that. Order. This is one of those things that's a little more about preference, but large muscles tend to burn more fuel. And so if you're going to exercise people, they tend to recommend starting with the larger muscle group, move to the smaller muscle groups. Start with multi-joint muscles, move to single-joint muscles, and start with higher intensity and then move into lower intensity. Okay? So start big, go small is what they recommend. Endurance training, we kind of talked about this already. More reps, low resistance, higher repetitions. Okay? Less weight, more repetitions, and strength is the exact opposite. Number of repetitions and sets, once again, that's really kind of varied. I've seen PTs do anywhere from 5 to 20. Okay? So it kind of is up to you. If you're doing 20, just know they're probably only going to be able to do about 2 sets of that versus they could do 3 sets of 15 and things like that. You just have to kind of think logically about it. You don't want to overdo it. Types of contractions, we've been over this like 3 or 4 times now today. So, we good? Okay, all right. And strength and endurance, like literally we just went over that. The notes in this are sometimes kind of awful. That's Module 5. Any questions over that? Really the concepts that you need to understand are fairly basic. We want to get muscles to fatigue. You want to know what fatigue is like and looks like on each patient. That might take 10 to 15 reps probably. And you want to make sure that once they get to that point, you don't overdo it. Once they get to where that is no longer fatiguing them, increase something. That really is that entire chapter. Everything else is kind of repetition. Then just kind of understand those principles. Overload principle, SAID principle, reversibility principle. Okay, I know those are important. And finally, number 6, unit 6. Okay, so this is something we've actually hit on quite a bit, and it was in 150, but we're just going to go real quick through it again because this is kind of the basis on how you build everything for Theric. I love this. Acute stage, that first stage is usually 4 to 6 days. That's So really, it's a week. Okay? So some of these times are weird, but just know basically for the first week, you're really in that acute inflammation stage. The first 72 hours of that are extremely sensitive, and the edema and swelling and stuff are at their peak. So really during that first 3 days, you're not doing much except rice. Okay? Once you've moved out of that rice, then you can start kind of doing some other stuff. You can start doing passive range of motion really in days 3 through 7, okay, unless it's contraindicated by some type of doctor's orders. But in general, you could start doing passive range of motion. You could start educating the patient on like what's going to be going on and how long it might take. You definitely don't want to stretch, and you can start doing gentle isometrics. Okay. It also says massage. This one, in general, you actually don't want to do that until they've moved out of that acute stage. You definitely don't want to do it in the first 3. I'm kicking everything today. You don't want to do that in the first 3 days, okay? Because massage actually increases edema, it increases blood flow to the area, and so it's just one of those ones I flat disagree with. In fact, if you were to go to a massage therapist after an injury and it's been within 72 hours, they would tell you no. They would just flat tell you no. So not only is there's rice, and I've got it in my book here. I'll show you guys real quick.
Right, did you say 3 to 7 days for the passive range of motion?
What?
Yes.
7 days for passive range of motion?
Well, it just kind of depends. It just depends on that particular injury. Definitely not within the first 3 days. And then sometimes in that 4 to 7 day period, you can start doing really light passive range of motion. But it just kind of depends. Let me find real quick.
Oh, too far. Maybe depending on your personality, you can do passive aggressive range of motion.
That's true. So, let me show you guys this. I found this and I really actually like it. It's from a different, oh, dang it. I'm impatient. Okay. So not only rice during that first week, but also harm. Okay, these things will harm. Heat will make it worse. Alcohol will make it worse. Running or resistance of any type will make it worse. And massage will actually make it worse. Okay? So definitely not in that first 3 days, but probably not even for that first week. I wouldn't do massage. Okay, so this isn't something, this harm won't be on your test, but it's something I found actually in a different program, and I really like it to kind of counteract rice. If you're still in that rice stage, you're in that harm stage also. No heat, no alcohol, no resistance or running, obviously, and no massage. Okay?
You mean alcohol applied topically or
No drinking. Yeah, don't drink because it thins your blood and it actually allows more fluid to get into that area. So any edema and swelling will get worse when you drink, and it'll continue the process. Like topical alcohol doesn't really have any effect on that at all. So, good question. Yeah, you gotta lay off the Bud Light. Okay.
No way.
So anyways, that's, I hear you guys. Brand, I'll do what I want.
Not the boss man.
You can't take my Pabst Blue Ribbon.
Natty eyes.
Steel
Boy, you
reserve.
really took a turn there.
All right.
I didn't even start
So
with
this
something
one-
good. You was like, well, from there.
This makes me laugh though because like the days don't match on this at all. You got for the first 4 to 6 days, and then the second phase is the 10 to 17 days. I don't know what happens to those other days. They just fall into the void and you
Chill
do
it out.
whatever you want. Not really. So, what I'm saying is the first week, 1 to 7 days, okay? And then for 2 weeks after that, you're really looking from 7 to 14 and really actually kind of 21 days. So the next 2 weeks. So that first phase is a week. The second phase is generally from another week to another 2 weeks. Does that make sense? So by the one, so phase 1, here, I'll write it. Is the acute phase. It's gonna be days 1 through 7 generally. Kind of depends, but generally that first week. Okay. The next phase is basically gonna run days 7 through 14 to 21 days. Okay. So another week to 2 weeks. Does that make sense? Okay. So in this stage, the inflammation starts to kind of go away. They're able to start kind of moving it around. You should be able to start to get some, the pain will start to kind of decrease, but you will have muscle weakness and functional limitations because you haven't been doing anything with that for a week, basically. Okay? So how do we treat during that phase? This is actually when we really are most important, actually, because if we get them moving too quick, guess what? We re-injure and we set them back. If we don't get them moving at all, guess what?
Contractions.
Yeah, they get stuck in that pain cycle and they don't progress. So this is actually where we are most important, but we have to be really smart and careful about it, and just kind of watch the patient. But this is where we start moving into active assistive range of motion, possibly active range of motion, maybe possibly starting to do a little bit of weight bearing, maybe some now this is actually where we can do massage and like scar massage and things like that and start getting things moving. Possibly maybe a little bit of light stretching we can start doing in here. But you still want to be careful with eccentric contractions because they're more damaging to the tissue, right? And progressive resistance exercises because they may not be ready to really tear muscle fibers down to build them back up, okay? But so that's where it's kind of a balance. We got to start trying to kind of strengthen them and get them moving, but we can't overdo it because we'll set them back, okay? And then moving on after that first, and this will vary depending on the injury. Moving on from there, anywhere from 21 days to 6 months and up to a year. They're in maturation and recovery stage, and this is the stage that they should be able to do pretty much anything to really start building up strength again, really start building up balance, building up towards running, and it's a slow progression, okay? The only thing you have to super worry about in this time period is that you just don't flat overdo it, okay? Like actually injure them, because the chances of re-injuring that same injury are pretty much gone. They should be pretty much healing. So this, when I talk about the different phases of recovery with each of the things that you guys are talking about, this is loosely what it's talking about. Having said that, not every injury is the same, not every surgery is the same, and so these might be extended out. You might have, like with a shoulder, okay, this first phase is actually 2 to 3 weeks, like a total shoulder replacement, and then you move into phase 2, which is, well, actually there's kind of a 2A, I mean a 1A with shoulder, then you start moving into Codman's and passive resistance, and that lasts for like 6 weeks, and then it takes 6 weeks before you get into this second phase, okay? But the concept is going to be the same overall. You're still starting with like potential range, passive range of motion, isometrics, trying to control swelling and inflammation and things like that. Then once they're ready and the doctor says they're able to move on, then you're moving into, okay, let's slowly start getting this moving. Let's kind of start building things up, maybe start doing light stretching. And then once they move on to that, with the shoulder, I'm trying to think, it's like, total shoulder is like 2 or 3 months before they move into this final stage where you can really start stretching them hard and strengthening them hard and things like that. So it varies, but the concept is still the same. There's the inflammation stage where you have to be super careful and protective. There's the, okay, now we're kind of in this middle stage where we can start moving it, we can start stretching it, we can start doing some light exercise against gravity and things like that. And then the final stage, we can really start stretching, start doing passive, progressive resistive exercises and things like that. Okay? Do those make sense?
And do you care what we call
Not necessarily, but I'm trying to think if there's anything in the book.
them? Just like, because
Well, on the test, I mean, I know it says acute, subacute, and then like maturation, right? Phases. And so, but if you just kind of say you're in initial phase, that's fine.
so
So-
you don't really care if you use like chronic versus maturation or anything?
I don't care.
Okay.
Just so you know, maturation, remodeling, chronic. Now I want to make a joke, but make mine the chronic. That's what I want you to say on. Anyways, that's an old rap joke. I'm sorry.
I got it.
So,
I got it
it's not even like I do that, but it just made me laugh.
often.
No, I don't do it at all often.
At all.
What are you doing? What are you doing? Okay. So things that can happen to people. Okay. They get injured. They either injure their tissue, their joints, or their bones. Okay. So a strain. What's a strain?
Tendon tear.
It's tendon or muscle. Okay? It can be either tendon or muscle, and it's a tear. Even a slight strain is a tear. Okay? Now there are different levels of tears. A grade 1 tear is just a mild tear, and it can take a day to 3 days to heal. Usually, though, if you rest it definitely within a week, you're all good to go. Okay? Then there's a grade 2 strain. This is a moderate tear. Okay, so the muscle, like if you were able to look at it, you would actually be able to see probably some tearing in the muscle. This takes a little bit longer and you're really going to have to stop activity for quite some time, usually 2 to 3, sometimes 4 weeks. Okay, for a mild. And then you can go to grade 3, which is a near complete, where that literally the muscle is just come apart from each other. It can be a full tear where the muscle literally disconnects from itself and they have to surgically repair that. or it can be just a really, really bad deep tear where it's still kind of hanging on, but just barely. That can take months to sometimes even longer. Okay. Same thing with sprains, except sprains are ligaments instead of tendons and muscles. Okay. And the grading of those is the same thing. If a ligament just has a small tear in it, that will probably heal on its own. It's a grade 1, usually goes away in 2 to 3 days, maybe a week. Okay. Grade 2 is there would actually be a visible tear in that ligament, and it would take 2 to 4, maybe 6 weeks. And then a full tear is obviously grade 3, and those are also some that sometimes have to be surgically repaired. They have to go in and re-stitch the ligament together. Okay, so strains are muscles and tendons, sprains are ligaments. Joint disorders are any type of inflammatory or non-inflammatory damage to a joint. The biggest ones are rheumatoid arthritis or osteoarthritis. Those are the most common types of joint damage. There are others though. So intervention for that, you're just educating the patient on how to protect their joints, how to properly rest their joints, keeping those joints moving as much as you can. You're using heat, depending on the situation, to help relieve some of the pain and try and just maintain range of motion as best you can. You might do gentle isometrics for strengthening to protect the joint but still get strength there. Okay, so this kind of treat that like the acute phase, and then training on how to properly position that joint when they're not using it to where things don't get worse. So if they have osteoarthritis or rheumatoid arthritis and they have their hand like this all the time, you want to train them to try and keep it in a flat position. You might even get them a splint or something that holds it in a better position so that they don't get stuck and lose movement. So that's kind of what some of the things we do to treat those, and we'll get into this stuff more. Bone disorders, mostly we're talking about breaks or osteoporosis, which leads to breaks. Okay. So if somebody has osteoporosis, you have to be just very careful with how you go about strengthening them. Okay. Flexion exercises increase stress, especially spinal flexion. And we'll go over this a little bit when we get to the spine section, but you don't want to have them do flexion exercises because it actually can cause those vertebrae to bump up against each other and they can fracture their vertebrae. But in general, any type of flexion exercise is putting more stress on a joint and on a bone. So just be careful. Flexion and rotation is even worse. Avoid intensity and resistance too quickly. Don't move quickly into those kind of things because you can literally have somebody break their bones. So just be smart about it and think about that. There are a bunch of different types of fractures. Most of these won't actually be super important, but might come up on your board exam, because most of these will either be repaired or set, and so it's not like you need to know necessarily, but they will come up on your board exams. I don't think there's actually any questions on your test about the different types. So there's just a normal bone, obviously. A transverse break is a clean break just straight across in the middle or on either end of the bone, but it just goes straight across, and it's called a transverse. An oblique is angled, okay, kind of like our obliques are angled, and so that just means it kind of comes at an angle. A spiral fracture, that's actually not a really good picture. Spiral fracture is caused by rotation though, and literally you can kind of see the ends of the bone will kind of like be almost rotational like that, and then the other end will kind of match it. Okay. going down, and so it kind of is jagged, almost like a valley or something, because the rotation as it was breaking kind of split everything up. Comminuted, there's just a bunch of little fractures, nothing like completely splits apart at all, but there's a bunch of small fractures all throughout the bone. Okay, those are often repaired surgically with like plates. Segmental, where there's two different technically breaks and there's a segment in between them. Okay, most of these are pretty self-explanatory. A volse is just a little piece of one of the ends of one of the bones breaks off. So it's actually not a huge, like a break of the shaft itself, but like a part of one of the bony prominences is broken. That's called an avulsion fracture. Impacted fracture is very similar to an avulsion fracture, but it doesn't completely break off. It's where, you break. Up there we've got the greater trochanter that has started to kind of break loose, but has not separated. This is a torus. It's just a growth that kind of happens in the middle of the bone. It's not an actual break, so the bone is like weird and crooked. If I remember right, these are actually often caused by a break that somebody had and they didn't know. And so when it grew back a little bit wonky and strange. And then a green stick is just a partial, sorry. No, it isn't. I gotta have my son change that. Anyways, or I can do it, but I don't want to learn. So green stick fracture it's just a partial fracture that doesn't go all the way through the bone. Okay? There's a little bit of separation there, but not the whole bone is broken. So the concept is that it's like a fresh branch off a tree. You can kind of break it, but not fully, because it's too fresh. It's not brittle enough.
And then don't kids get that a lot?
Yes, mostly it happens with kids. They get green stick fractures because their bones truly haven't gotten hard enough yet. And so you do see that more often, especially in like 2-3-year-olds and things like that. But it can happen in other people. All right. So, if somebody has a history of falls and they're complaining of pain, it's a good chance there might be a fracture there. Localized pain that is aggravated by movement. Okay, so if you're trying to see if somebody has a fracture, if they fell and they're like, oh, it doesn't hurt too bad, and then they try and move, okay, they're like, oh, yeah, that's bad. Like when I broke my 4th metacarpal, it was all good. I fell, I was like, not that big a deal, it hurts. And then I tried to do flexion, and like I could literally like feel crunching and stuff in there. Like, oh, that's not good. Okay. So if pain increases as they move, that's a decent sign that it might be broken. But the problem with that is you would still feel that with a sprain or a tear, right? A sprain or a strain as well. Muscle guarding is passive movement. If you're trying to move them and they have pain, decreased function of that body part. These are actually the really good ones. Swelling in a local area, deformity in a certain area. If you're looking at it and you're like, wow, that really sticks out right there. Okay, it's a pretty good sign that it's broken. Abnormal movement. Like if the joint isn't moving properly or moving at a weird angle that it didn't before. And then sharp, localized tenderness at the site. It's a really sharp pain in a specific location. Okay, it's not kind of more like that really bad ache that you get from a strain or a sprain that kind of goes up and down. It's like, no, it hurts right here. Pretty decent sign there might be a break. That just becomes important because you will have patients that even if they don't fall when they're with you, will not listen to you and will have a fall, and they'll come and get you and go, what do you think? Okay. If that ever happens, it's okay to talk to the patient a little bit, but always get a nurse or somebody else. Okay. Just so you know. Because I have had people go, oh, she fell. Can you come help us? Well, I can help you get her up once the nurse has looked at her, but I don't get to diagnose. Okay, but it can also give you just an idea of what might be going on with them. Bone healing phases. Okay, how our bones heal, they actually go through the same phases. They go through an inflammation phase, a reparative phase, and then a remodeling phase. The first thing that happens is the bone bleeds, and it creates this little pocket of blood and minerals and nutrients that kind of surround it to try and start pulling everything together. Then we move kind of into this second stage here, which is reparative. It builds a callus, basically a scab or a scar on the outside of the bone, and then that bone starts to kind of heal. This is basically 1 to 3 days after. This is basically 3 days to 2 weeks-ish. This is like 2 to 4 weeks where the bone starts building in that internal material, and the callus starts to kind of harden, but it's still kind of spongy, and then it's healed. That usually takes 4 to 6 weeks if you're really young, 6 to 12 weeks if you're older, or if you're a smoker or have diabetes. Diabetes, yes.
Diabetes.
Diabetes.
So what was the timing on the on those again?
So this hematoma forms in that first 1 to 3 days. It's kind of that, and this stays in that state until basically the first week. This is a week to 2 weeks. This is basically 2 to 4, and this is 4 to 12 weeks, depending.
That's 4 to 12 on the rigid internal fixation.
Basically. So typically children heal within 4 to 6 weeks, adolescents 6 to 8, and adults can be 10 to 18 weeks. Like I said, though, there are factors that can increase any of those times. Adults, and it just says adolescents is 6 to 8 weeks. Really, until you're about the age of 40, it takes about 6 to 8 weeks to heal a break if you're a normal, healthy person. If you're not a smoker, if you don't drink a lot, if you don't have the diabetes. Okay?
The sugars.
The sugars. And that's really it. That's really it.
Blew through those.
Any questions? All right, so next class, we will take our test, and then we will start our presentations. We'll be moving into the shoulder. 7 is basically just like scapular winging, really, and there's some other things that we'll maybe hit on a little bit. So just Alex would be up for sure, just so know that, okay? And then we'll kind of move on from there. You can kind of know if you'll be going Thursday by looking at the order of the things in the next chapters. It goes scapular winging, and then I think slap repair, and you can kind of go down the list. I doubt we'll be able to get through all of unit, so we'll be going 7 and 8 next class. So I doubt we'll be able to get through all of 8, but be prepared just in case. Okay, and we'll just kind of go from there. Any questions? Over any of the stuff from today? I kept you guys a few minutes later. All right. So if as you're going over your stuff to get ready for Thursday, either for the test or for your presentation, don't hesitate to text me. Okay. I don't always get to emails, like I do those at work, okay? I'm not jumping on my computer checking emails at home, but I do check my phone, and it's perfectly okay to say, hey, I got a question, and shoot me a text, and I almost always answer. For those of you who have done that, you can verify, okay?
You said the who you gave was for the midterm?
It's for the midterm, yeah, it won't, I mean, there might be a few questions that might help you on the first test, but not a whole lot. Okay, it's really more for the second. But that study guide is pretty set up and decent. Okay, you should be, and most of this stuff is review stuff anyways. This first test isn't too bad. You guys should do okay on it. I wouldn't stress too awfully about it. Just make sure you know the stuff from the study guide, and you guys should be pretty good. Okay? Anything else? All right, let's put the room back together.
Question,
Sure.
For the correct